So we'll go to now to the next section, and we'll talk about our experience and how we started, what we learned. So we started our program in September of 2011, so a long time ago. And we went through 3 stages. We're still going through these stages, by the way. So our first stage was utilizing a pure diagnostic unit, and I'll show you pictures of that. Actually, the pictures you saw of the ClearPoint were pictures of that diagnostic unit. From 2011 to April of 2013, we used this purely diagnostic unit for our ClearPoint cases, for our interventional cases. And we did a build out to build an interventional unit, but it is a hybrid unit. It still is, it can be used as a diagnostic unit. And that build out took till 2015. And we're still using that interventional unit from 2015 till present. And at this time, we have a intraoperative unit that is being built in a new tower that's going up. And God willing, it'll be completed in December of 2022. So we're very excited for that. So that's basically the outline of our journey. So far, we have done about 101 DBS cases, 198 leads placed. Some of these cases were unilateral. We've done 46 MRI guided ultrasound cases. 13 lit procedures. It's a small number, but I'll tell you why, and 2 biopsies. And what has really worked for us, but also hampered our use, is this block time approach. Because we are bound to the Department of Radiology and they're graciously allowing us to use their equipment, we've come up with a block time where they give us Mondays. Well, initially when we started, during this period of time, for those that were part of ClearPoint at that point, they remember our block time was Sundays. So we would do these procedures on Sundays, and slowly we started to move to Mondays. But you know, some of the biopsies and some of the lits don't lend themselves to an elective process. You know, so if someone comes into the emergency room with radiation necrosis or with a tumor, and we already have cases booked, it's difficult to do that. So our lit procedures have been limited because of that. And similar with the biopsies, we anticipate once we have more days where in the intraoperative unit we'll have almost every day available, these numbers will drastically change. That's our experience, and we'll, in the remainder of this webinar, we'll really focus on the build out that took about a year and a half to 2 years there. This is, and most of the pictures I'll show you is from this manuscript, so it's you know, available online as well. So the first issue is the physical layout question. When starting to think about a program and what, you know, and building an MR unit. So the options are, if someone's lucky, a de novo build. Here's a flat piece of ground. This is, you know, go ahead and build. Or the other alternative, which is for most of us, is there's an existing space and we have to try to fit our design into that existing space. And certain things even go more into that is, do we design the whole suite or only part of the suite? And I'll show you our experience with that. And then certainly if we're building an intraoperative MRI suite, we have to ensure consistency with the state regulations for the operating room. And this, I'll mention some of them here, but I'll show you some more. You know, having a secure antechamber, a scrub sink, recovery area, holding area, all these are state mandated regulations where if you're going to put a sign up and say this is a interventional operative unit, these things need to be followed. And certainly other options to consider is, you know, mobile magnets versus stationary magnets. You know, which one do we go with, and there are implications for both. So let's talk about that last option. So the option of a stationary magnet. So this is basically two adjoining rooms with an intervening door. And there is this is the operative side. These are the lights and the anesthesia machine and the operating room bed, and here is the MRI. And in a stationary magnet situation, once the surgical part is completed or some imaging needs to be done, the patient is wheeled into the MRI, and the MRI is obtained, and the patient goes back. So this is the stationary magnet concept. The mobile magnet concept is again, two adjoining rooms where operations are done here, but the magnet is in an adjoining room with rails. And what happens is, as needed, the magnet is then pulled over across to the patient. Imaging's done, and the magnet goes back. There are multiple implications that go into this decision making, and I think this is a from the article. This is a table that kind of just summarizes the cost of build. Of course, excuse me, mobile magnets. There's a picture of a mobile magnet, and you see the rails. The cost of build are not only of the magnet, but also of the rails and the structure that supports that. So often it is as much, if not more, than the magnet itself to build that. So the costs are more, but yet the utility is great, and there are certainly some institutions that are doing it very successfully. The space requirement, certainly, to have the rails and so forth, you need to have the rooms adjoining directly. It can't be an L shape. So there's a lot that goes into that. And then the surgical limitations, of course, with movement of patients, you have to be careful. Certain things need to be considered in terms of anesthesia machines when we move the patients, whereas when the MRI moves, it's a different set of concerns. The anesthesia machine can stay there, but you have to make sure that surgical instruments are MRI compatible. So another advantage of using a mobile magnet is that regular instruments can be used, but they have to be removed. Where if we're using a stationary magnet, we cannot, certainly if we do the surgery in the magnet, we can't use the non-MRI compatible magnets. So that's certainly area to think and discuss. So this is a picture of what the room that we had. So this is the suite that we had. This one MRI was here, the control room was there, and this room was actually a linear accelerator, believe it or not, and that's what it was there. So not only was there a linear accelerator, but the walls were lined with lead blocks. So all around was lead blocks in this. So the cost of converting this was not small, but yet the walls were there already. So we were fortunate that there was already a room there for us to proceed with. So the cost of build obviously has to be considered, and what goes into that is do we shut down this? If we wanted to change this whole thing, do we shut down the MRI? I mean, that's a huge revenue generator for the hospital, and shutting that down at cost for 2 years is really not very financially advantageous. And if we're going to stage it, it's very complex. Patients are coming in and going. As I said, lead was being taken in and out of the room. So there was a lot of balls in the air that had to be staged properly, and every site would be certainly different. And the challenges of trying to fit what we need into this space, because there are certain regulations, both from a operative standpoint and also from an MRI world standpoint, that we had to take into consideration. So ultimately, this ended up being our final design after multiple iterations, where this became our second MRI room. We utilized the control room, so this part we did not touch, and we basically yeah, this is what we talked about. We basically designed only a particular part of the room and used a stationary magnet. Obviously, there was no room for us to put a rail and a mobile magnet. And in terms of considerations for the OR, so again, we have to have considerations for the state regulations for OR requirements as well as MRI. So we have to be paying attention to two worlds. So we have to have a secure antechamber in any OR, at least in New Jersey. This is what we need. We can't just go directly into the operating room, and this is what was designed. The scrub sink needs to be there, and so part of the room in the back we placed for a scrub sink. I'll show you pictures of that. We definitely need a holding area and a recovery area, and certainly ventilation it needs to be addressed in a OR space. In terms of the MRI world, you need shielding in the room. You need access to the control room. A computer room needs to be there, and this is where we decided to put the computer room. And safety is very important. Who comes in and goes out? What kind of equipment we use for this? And then we'll talk about some of those considerations. So here's some pictures of what we showed. This is the MRI room. Here's our control room. So this is our control room looking into the MRI space. This is our scrub sink, which is in this area. And the secure antechambers here. This is a door going to that, and this is the picture of the MRI, and this is our holding recovery area. So the patients are recovered in there. In terms of satisfying MR world, well, we had to have copper shielding in what's called zone 4, which is where the MRI is located. We have to have RF shielding for doors. So there's, the doors are wooden and they're specialty doors, and one is automated, the other one is not. Data links all need to be over fiber optic cables, and electric cables needed to be properly shielded. The waveguide, which is, and most MRIs have it, is basically a conduit through the copper shielding. But it was very important for us because some of the equipment we use is not MRI compatible, and we needed to have a way of bringing that material into the MRI. For example, bipolar electrocautery. We use it, but the machine is outside and we run the wires through here. And our pneumatic compression device for the legs. Also, the machine is MRI incompatible, but the tubing is all plastic. So we run the tubing through here. So that's a very critical part of our design. And of course, any design will need input from the MRI vendor. So magnet and coil, in terms of selection, obviously there's options for 1.5 Tesla, 3 Tesla. So much goes into that. We chose a 1.5 Tesla with a bore size of 70 millimeters, and even nowadays all of these magnets have a fairly large bore size. Coils, we chose flex coils. I'll show you a picture because we had to for ClearPoint. But that goes into our decision making. Certainly, the magnet needs to be compatible with the coils that are available, and compatibility with existing platforms. For example, when MRI-guided focused ultrasound initially was developed, it was only with the GE platform, and Siemens was not able to use it. We use a Siemens machine. Other things, engineering of patient movement is very important. How patients move in and out for stereotactic procedures. Accuracy is very important. Siemens happens to have a very accurate chain movement, which is not there for the other vendors yet, although I hear that they're working on it. So that has something very important to do as well. And certainly local vendor contracts with the hospitals and the networks go into that. And this is a picture of our flexible coils that we use for our stereotactic procedures. So for air circulation and ventilation, in the OR, there is a lot of data that shows air curtain systems are required. What are those? So there's these laminar air diffusers that direct the air straight down internally, and there's air curtains, and you see these guys out here. And what they do is they produce higher velocity air, higher than the middle air diffusers. And what that does is it creates a constant velocity differential between inside and outside the curtain, and this prevents recirculation of contaminated air back into that space. And of course, we use the high efficiency air filters. And it's kind of a schematic of that, what that may look like, where there's higher velocity air coming, developing a curtain around the middle parts of the air diffusers. Lighting. So there are MR compatible lighting systems available. There are LEDs. What I would say, what we learned was they're turning on and off is a button on them, and it becomes extremely inconvenient. So if anyone's considering doing this, I would suggest putting them on a one circuit with one button to turn it on and off at the door. Because it's so inconvenient, we stop basically using them, and ultimately this is what we use. We have loops with lights, personal lights on them, and we have not had any trouble, and the illumination has been great. So surgical and anesthetic equipment. So ASTM, the American Society of Testing Materials, gives MR safe or conditional or unsafe designations to devices, and this has to do with where in the 5G line they can be used. So MR safe can be used in the 5G. MR conditional has to be used with certain parameters. What falls into this is a lot of implants, DBS included, the battery, I mean. Pacemakers and so forth. And MR is unsafe, of course, it can't be in zone 4, and zone 4 is really where the magnet is, and I'll show you pictures of what that is. So what we use is that we have an MR compatible anesthesia machine. This is our vendor. There's many vendors out there. We have an infusion pump that the anesthesiologists use that is MRI compatible. They choose to use it, leave it outside, and bring the tubes in through the waveguide, but this is capable of being used inside the 5G line. A syringe driver for contrast, anesthesia monitors for pulse and the physiology of the patient. We have one in the room. We have an in vivo, but Philips makes them. They're all kinds, and one outside the room. And of course, I told you about the pneumatic compression device. This is not MR compatible. So, excuse me, any vendor can be used, and we bring the tubes, which are plastic, through our waveguide. And of course, the instruments that we use, there is a growing, but still a small number of vendors that provide the titanium tools that we use. This is basically our toolkit. I often call it the Toys R Us set, because they're kind of soft and flimsy, but so far so good. We've used them, and we have an MRI compatible drill that we're using, and I believe there are more vendors coming on that are developing these. The next section, which is safety, is enormously important. Anyone developing an interventional MRI suite, this is really enormously important. No one wants this kind of publicity. This is basically a child that died when an oxygen tank went into the MRI unit. So I mean, this stuff is really, really important. There is no gray area with MR safety. It's clearly black and white, and we need to follow that. And for a safety program, knock on wood, we've been very fortunate over the past decade, really. But every person needs to be involved and be aware of the safety issues. So in terms of safety issues, access control is very important. Who gets into out of the MRI? So I'll show you pictures of what these zones mean, but zone 3 is really the zone before you go into the magnet room. I cannot get into zone 3 without a MR tech or someone that has special certification, and this is important. So only certified personnel is called level 2, at least in the US, is called level 2 advanced MRI safety personnel are required. I'm a level 1. I don't have a level 2 advanced MRI safety training, so I cannot be there unsupervised. So, it's very important. That includes anesthesiologists, surgical staff, others. We have to be accompanied by someone that is a level 2 certified in zone 3 or 4. Certainly safety training. All staff entering the interventional unit must undergo MR safety class. With the MR safety officer, we have a designated safety officer. There's an annual refresher course and exam. All surgeons undergo MRI safety education and need to be proctored by the primary neurosurgeon in our institution. Of course, staff has to know their responsibilities and workflows. Checklists are very, very critical. There's been demonstrated in the literature that they add to safety, and we utilize it almost in an OCD fashion. So let's talk about these zones, and these zones are defined by the American College of Radiology. Zone 1 is basically everywhere else besides the MRI unit. Any part of the hospital that's not near the MRI unit is a zone 1. Zone 2, so here are all freely accessible areas without need for supervision. Zone 2 is a zone that separates the restricted zones to the non-restricted zones. So that's really the area entry, at least in our design. That's what zone 2 is. Zone 3 is an area near the magnet room where the magnetic fields are sufficiently strong to present a physical hazard to unscreened patients and personnel. So most of that area is a zone 3. And then zone 4 is the actual magnet room. This is where the fields are the highest, and all ferromagnetic objects must be excluded from this area. And as you know, we don't even allow much ferromagnetic objects into zone 3 for safety reasons. So checklists have been demonstrated in multiple fields that they increase safety. So we have several checklists. There's a surgical pre-procedure checklist that's done in zone 1. All consents are signed there. There are MRI sheets, lab work, everything's checked. IVs are placed there. Then and that's what the checklist checks for all of these things. The second checklist in the surgical holding area in zone 3, and this is where we check to make sure surgeon and anesthesiologist are seeing the patients. All staff and vendors are MRI cleared and in appropriate attire. And then there's another checklist we do, the pre-procedure walkthrough, which is prior to patient entering the room in zone 3, making sure that there's been terminal cleaning of the room, the implants are available, anesthesia surgical equipment's functioning, and MRI and our guidance software, ClearPoint software, is functional and communicating. This is done before the patient goes into the magnet. And then in the magnet, we do an MRI surgical briefing. In zone 4, patient safety checks, padding, making sure intravenous lines are long enough, patient monitors are working, anesthesia circuits are working. And there's basically, it's almost like, you're you're getting ready to ensure that patient is going to be safe for a period of time without direct access to the anesthesiologist. Now, in our world, our anesthesiologists sit in the control room, but they don't have to. They can sit in the room, but we make sure that we have adequate safety measures, that is not a safety concern. And then final pre-procedure timeout, and we ensure that there's a correct patient and the correct surgery, and everybody's available. So the next issue is infection control. I mean, this is a big deal, doing these procedures outside of the OR. So we need to make sure that there is some stop gaps to ensure that we don't develop infections. There's currently no formal recommendations from any professional or accrediting agency for cleaning in an IMRI suite. So There are some guidance for MR safe practices from the American College of Surgeons. That's what we use. So design areas should be easy to clean. Surfaces can be scrubbed, seamless flooring and so forth. And we followed that. And then there's terminal cleaning guidelines from the CDC. Excuse me. Before and after each interventional procedure, this is what we do. And these are enumerated on the CDC site if there's anyone that has interest. Thorough cleaning and disinfecting of all surfaces, removing all used linen and surgical drapes, waste suction containers, kick buckets, not very surprising. Removal of all detachable objects, cleaning and disinfecting of all lighting, and cleaning and disinfecting the MRI table and MRI machine. This is what we call terminal cleaning in our institution. And then certainly emergencies. If there is an emergency, what do we do? And the emergencies can be divided into two separate categories: patient emergencies and magnet emergencies. For patient emergencies, there already is a protocol from the American Society of Anesthesia for cardiopulmonary emergencies, and this is detailed, and this is what we follow. Again, thank God we have not had to so far, but we are aware of the steps. Patient is moved to zone 3. Code cart, which is in zone 2, is moved to zone 3. MRI scan door is locked once the patient and staff have left the room, and MRI and staff stands in the security door to assist and monitor the code team that comes to zone 3. So the magnet emergencies, or the quenching, is the most significant magnet emergency. Excuse me. And this really, again, thank God, has not happened, but it can. And what happens is that coils lose their absolute zero temperature and helium escapes from the cryogenic bath. And if helium is not vented out, it quickly displaces oxygen in the room and becomes a dangerous situation. So our protocol is that a level 2 personnel initiates the quenching protocol. There's shutdown buttons in zone 3 and 4, and this breaks a valve that expels helium to the outside of the building. And there's an auxiliary pathway available as well. And certainly there's a need for oversight. So we have continued review of our practices and protocols. We have regular meetings in our Neurosurgical Quality Council, and informal but frequent communication between our team members. And we continually update and revise our checklists. So in summary, MRI is becoming really an indispensable tool for neurosurgery programs. As you saw, the applications are expanding rapidly, this particular tool, it is becoming really indispensable. So expansion into MRI space offers increased opportunities for treatment of neurological disorders. And I would venture to say that it almost is going to be a requirement in the next decade. But expansion into MR space presents unique challenges which can be overcome with a dedicated interdisciplinary commitment. So that is the end of my talk. Thank you for your attention. I hope I did not bore you, we'll see if there's any questions.
Thank you, Dr. Azmi. That was a great presentation. And we do have some questions, but if anyone else has something in their mind that they would like to ask, please do enter that in the Q&A box at the bottom of your screen. So just to get started, first question, how have you and your surgical team adapted your skills from the OR to MR? So things like ergonomics, you're working horizontally versus vertically. How did you adapt, and how did you help your team adapt to that working environment?
That's a great question. I think one, I would say, try to answer that in two parts. One is myself and other surgeons, and two is the staff. And there's different models for this, and it also depends on the location of the magnet. There's models of having the nursing team from the operating room coming down to radiology and helping with these cases. The model we utilize is cross-training our radiology nurses to be able to do these interventional procedures. So we spent some time, the nurses rotated in the operating room with us. They saw a lot of DBS cases. Initially, that's how we started the program. And so they are the radiology nurses have become really experts. So we do not rely on the nursing staff from the OR at all. And it's strictly a radiology run endeavor. And again, this will depend on the institution, on the logistics, and so forth. So and anesthesia, they come down to MRI quite often for sedation cases. So it's really just a little bit of an expansion of what they do. So it's not a very complicated adjustment for them. But from a surgeon standpoint, there are limitations that are presented with this. As you saw, our tools are limited, certainly. The bed height is limited. Lighting can be limited. So at the present time, our interventional suite's ability to do anything more than stereotactic procedures is very limited. So we're able to do the procedures I showed you, which are DBS, biopsies, LITs, and anything that is basically burr hole procedures, and certainly the MRI-guided focused ultrasound. But as we go into our next stage of development, which is the adjoining, and I would be happy to give a talk on development of that space and lessons learned. But once we go to that environment, where the MR is separated, it's a standing MRI separated from the OR space, that allows for a lot of maneuverability and we bring the patients into the scanner to scan them. So I hope I answered that.
I think that was great. Thank you. A couple questions related to kind of your experience at the time of development and kind of now. So we'll start with, this publication came out in 2013. In the nearly 10 years that have passed since then, are there any factors that you think are easier to manage now? And are there any factors that you think might be more difficult to manage in the current state of things today?
I have to think about that one. But the thing that comes to mind, and at least in the US, resources have become really scarce, especially after COVID. So since the time that article came out, it's been a while since COVID, but more recently, any kind of endeavor is really affected by our reality of staff availability. And I hope in other countries that you guys have this solved. But this is a challenge that regardless of where in the hospital we're facing tremendously.
In the context of COVID, do you think there's anything that is different or more sensitive now, thinking maybe like infection control or other hurdles that you might have to clear if you were to set this up today versus what you did in 2013 in the context of COVID?
So I would say, I can tell you my experience. I don't think that changes things, and I can tell you from our experience in the operating room, it's almost, we went through phases, and New Jersey was hit very, very hard with COVID during the peak of the pandemic, where we had to shut down all surgical treatments for a long period of time. And once we started, there's been some bouts of COVID, but we've not shut anything down. So it's almost like a part of reality right now, and I don't think that affects the day-to-day stuff, except for what we discussed, in terms of staffing and those resources. Now, if I can go back to your prior question, I think between 2013 and now, what's different is, I think, precedent. And in a program that is looking to start their interventional endeavors, there is certainly precedent of other successful institutions that have done this. And the precedent for delivery of care to patients is there for them to be able to partake in these therapies that otherwise they would not. So that's very important. And another thing I think that's different, which I alluded to, is really the need of neurosurgery for an interventional space. As we discussed, there's more therapeutics coming out that we almost need an interventional unit to be able to deliver this, convection enhanced delivery for chemotherapeutic agents, gene delivery, thermography to ensure that our lesion is not causing issues and we're adequately lesioning. So the time is right for the interventional unit.
That's great. And that leads us into another question that we got about if a pharmaceutical company or a sponsor is considering selecting sites for a clinical trial that will use ClearPoint to deliver gene therapy. Do you think that it's better to only consider hospitals that have that intraoperative MRI suite, that have an IMRIS or an OR right next door? Or do you think that it's possible that those studies could be done in hospitals that only have a diagnostic scanner set up like your own?
So because of the variability in resources and in what's available there, some institutions have an intraoperative MRI, and some institutions have a kind of a borrowed MR from radiology, and the rest somewhere in between. And I think it depends more on the experience of the team as opposed to the type of unit. I think if there's a pharmaceutical company that is interested, I certainly, having the mobile magnet and whatnot, I think is really low on the list. I would consider more the experience with the team of numbers of cases done and safety. Certainly the last thing that is needed in an experimental trial is the safety variable with a team that may have the latest equipment, but not the actual experience of performing these surgeries. So that I think that's you rely on these teams that have been doing this for now over a decade across the US and probably the rest of the world, some institutions as well. And our goal is to ensure safety for our patients and to do these procedures well. So with the experience, I think that's the number one thing I would look at.
Fantastic. Thank you so much. Well, I think that's about it for all of our questions here today. So I appreciate your time and your expertise that you've shared with us. And I'd like to extend a future offer to if you want to speak about your future design of your MRI that you're building right now, please come back to us in a year or so. We'd love to hear more about how that's going.
Great. Thank you very much for the invitation.
Thank you, Dr. Azmi.
Thanks.